Good afternoon, everyone. Thank you for joining us. Good evening for the East Coast. It is an absolute pleasure for me to welcome you to our very first ElevateMeD talk on Native health disparities with Dr. Erin Baya. I'm Dr. Alyx Porter Umphrey, the founder of ElevateMeD. My husband, Dr. Gregory Umphrey, and I experienced a gap in our career matriculation that ElevateMeD was really developed to fill. Through our ElevateMeD Scholars Program, we're providing scholarships and support to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. It's really an honor for me today to introduce our moderator for today's program, Dr. Erin Baya. Now, Dr. Baya joined the ElevateMeD family in 2020 as an ElevateMeD scholar. He came to us as a fourth-year medical student at the University of Arizona College of Medicine, Tucson. And it has just been so beautiful to watch his growth in the program throughout his residency at the University of Utah. And now, as he continues his journey as a family medicine physician, practicing at home in Canyon de Chelly with the Navajo Indian Health Service. Welcome, Dr. Baya.
Thank you, Dr. Porter Umphrey. Yata she Dr. Baya inshe. Maidish kijin shen twitchin basichin, twitchin she twitsin nationala. Good afternoon, everybody. My name is Erin Baya. I am from the Navajo Nation. I am happy to serve as the moderator for our program today. We are here today because ElevateMeD exists to promote physician workforce diversity as a tangible step in eradication of health disparities. Native communities, well rich in history and contribution, are disproportionately impacted by inequities related to health and access to healthcare. Today, we will discuss opportunities for impact and change ranging from workforce to disease management as we seek to promote health equity for Native and Indigenous communities. Thank you for joining today's conversation and honoring Native American Heritage Month with us. All right, so I'd like to introduce all of our panelists today. So my first panelist I'd like to introduce is Dr. Thomas Blair Matheson. Dr. Matheson is the president of the Association of American Indian Physicians, a medical director for National Medical Resources, and trauma surgery and emergency medicine physician. A North Dakota resident and a member of the Cherokee Nation, Dr. Matheson primarily serves rural Native American populations. In addition to his Stanford degree, Dr. Matheson holds an MD from the University of Oklahoma. He completed his residency in general surgery at Maricopa County Hospital and the University of Tennessee, Knoxville, and his residency in family practice at the University of Oklahoma. Thanks for being with us, Dr. Matheson.
Thank you. Thank you for inviting.
All right. Our next panelist, I'd like to welcome Dr. Jennifer Erdrich. Dr. Erdrich is a practicing surgeon at the University of Arizona, specializing in operations for melanoma, sarcoma, and breast cancer. She completed her education and training at Stanford, Harvard, and Cedars-Sinai Medical Center. Her research is focused on cancer prevention and control, particularly for Native Americans. Her paternal family is Turtle Mountain, Ojibwe. She strives to expand the surgical oncology resources available to local tribal communities through multidisciplinary approaches that leverage innovation and teamwork. Welcome, Dr. Erdrich.
Thank you for having me.
Next up, I'd like to introduce Dr. Megan Corn. She's an alumni of the ElevateMeD Scholars Program and based in Menlo Park, California. She's an enrolled member of the Chickasaw Nation with ancestry in the Cherokee and Choctaw Nations as well. Dr. Corn is a first-year resident OBGYN with Stanford University. She graduated from California Polytechnic in San Luis Obispo in the degree in biology and a minor in biotechnology and Spanish. She earned her medical degree from the University of North Dakota. During medical school, she was able to focus on Indigenous health and work closely with the American Indian population of the state. Her interests include identifying and mitigating health disparities among marginalized populations. Please welcome Dr. Corn.
Thanks so much, Erin.
All right. Well, thank you everyone for joining us today. Let's jump right in. So our first statistic today is Native Americans comprise 3% of the population, yet account for only less than 1% of the workforce. This was according to the American Medical Association. So jumping straight to our panel questions. So we're going to talk about the past and how we got into our medicine and our pathways in our careers. So let's start off here. Let's start off with Dr. Corn. Tell us about your pathways to medicine.
Thank you so much for the question. I have had an interesting path. I told my parents when I was 5 years old that I wanted to deliver babies. And that has just been my trajectory ever since. I think it started hearing my mom talk about her different experiences with obstetricians. She had two different ones, and one was very positive and one was very negative. And I think that being in this role and what I had seen was just the profound impacts it can have with every single interaction of patient and provider. And so it was just something that I saw early on in life for myself, and then just continued to pursue and found more and more of an interest while I was on this trail, and then found myself in North Dakota where I was able to receive a really good education, especially for Indigenous health. And I'm happy to be at Stanford today.
Thanks, Dr. Korn. Dr. Matheson, what brought you to medicine?
I took more of sort of a traditional pathway. My dad was one of the first Native American docs in the country back in the early 60s. He was one of the guys who started the AIP in 71. So I had dad as a role model. Dad did sort of the family practice, everything that came through the door, country doctor. Dad worked in IHS at San Carlos, Arizona. I took a little different pathway. I was much more kind of trauma, surgical oriented. Could I take it apart, put it back together, make it better? Love trauma, the gunshots, sort of the rush that goes with it. So a little different pathway than dad, but I always knew I wanted to be in medicine, watching dad and the rest of them try and improve Native American healthcare. I just kind of wanted to do it from a little different angle.
Thank you, Dr. Matheson. Dr. Erdrich, tell us about your pathways to medicine.
So somewhere in childhood, I at least figured out that I wanted to be a doctor, and that was so early on. I really kind of can't like pinpoint what spurred that, other than I remember my grandmother saying that whatever any of us did, we had to figure out a way to give back to our communities, whether it was through art or through science. And so I kind of early on gravitated toward this idea that I think the way to give back is to be a doctor. But then when I was in medical school, the reason why I picked surgery, because that was a surprise to me, was that it was the place where I actually felt the most connected to my heritage. I found a lot of parallels between the teaching style in surgery and the way my grandmother taught me how to bead. So like she was kind of like my first attending and showed me like it's that same kind of idea. Someone's over your shoulder and they're teaching you something with your hands in very like painstaking, meticulous attention and helping you correct and helping you improve until you're independent on your own. And so I just fell in love with really that educational style, felt familiar between our beading circle and really the circle you make around the OR table.
Thank you for sharing your story. So my own story for medicine actually also stemmed from my grandfather, who was a traditional healer in my culture. So early on, I got to witness my grandfather help patients, heal patients through cultural ceremonies. And I love the fact that my grandfather was always on call. By that, I mean that any patient that came to him in the middle of the night, morning, any time of the day, literally, he will stop what he's doing and go out of his way to help out his patients. So I got that very early experience for myself for that pathway into medicine. Going through my education, I wasn't too sure if med school was not for me. So I was a global health major at the time, but I knew I wanted to go back to medicine eventually because I know I wanted to go back to my culture, back to my tribe, and to be that family medicine physician who wanted to see anybody and everything. And here I am living the dream. All right. Next question is for you, Dr. Korn. How did your native culture influence your decision to medicine?
Yeah, I think it's a good question because the initial inspiration when I was 5 years old, I'm not sure where it came from, but I think my path has more been carved by Native influence along the way. Throughout the path, there was, I think really early on, it was evident to us the disparities and the differences in our communities versus predominantly white communities and outcomes. And at a younger age, realizing that that's not fair and how can we change it? And so it came more from this drive of we need to make change as my passion. And so I think that that was one of the reasons that led me to North Dakota with one of the highest Native populations, and abundant resources for us as medical students there, to be able to provide more services and research while we were there. So I think it was an interesting question of where it all came from and why I decided to go into this. But I do think what Dr. Erdrich said was very beautiful, that when you're in this room, it feels like a community that you have, and it is a similar feeling.
Thank you for sharing, Dr. Korn. Dr. Matheson, how did your Native culture influence your decision to medicine?
It sort of drove my focus to give back to the Native population because I'm a little bit older. Watching Dad when they started the AIP in '71, they could truly only identify 15 Native docs total in the entire US in 1971, probably a few more. But you looked at that number and went, dang, there's not enough of them. And so it drove me to stay connected to the Native population, to give back, to work on the mentoring thing, to try and open the doors for those of you who are coming behind me, like Dad and Everett Rhodes and all those guys opened the doors for me.
Amazing. Dr. Erdrich, how did your Native culture influence your decision to medicine?
I'd say that both my cultures, my Native and non-Native, influenced it in a compare contrast kind of way, kind of like how Dr. Korn was describing, like this, even early on in childhood, this impression that there was a difference. So my family is all in North Dakota, really both sides, but I grew up in San Diego and experienced, access to really everything at your fingertips. And then I would spend summers with my relatives in North Dakota and just see really a completely different world. So I think it just similar, there's like a similar theme, I think, kind of running through everyone, coming to the sense that there's a difference, and entering medicine was a way of social justice to give back to our communities.
Great, thank you for answering. So my own specific culture, I believe that us as Native people, we've always had healers in our past, either through ceremony, chanting, singing, herbal remedies. So that mindset, say my own grandfather, but in the end, I always wanted to be a provider that continues the allopathic side of medicine to serving my patients, and to be that provider who looks like their patients, knows their language, understands their culture. So now being home back in my tribal hospital, now I see the full circle of that, interacting with pediatrics, adults, elders. It's just come full circle, and I'm very proud of that. All right. Next question, Dr. Korn. How does the Native history continue to influence Native health disparities?
This question is, I feel we could talk about this for an hour just in itself, of how the historical trauma has led to today. And I don't think it's simple enough to just answer in a few sentences, but we can start with the forced relocation and genocide and how we were pushed out across our land, and how the impacts of that. If you lose your home and then your children are taken away, sent to boarding schools, they lose their culture, of course there are going to be impacts down the line from that. And then I think, now we have all the ACEs, adverse childhood experiences, that there's a lot of work being done on as repercussions from that. And it's this cyclical trauma that I think is very, very hard to break. And that's what we're working towards now as physicians. But I think there's a lot we could unpack with that, but I'll leave it there.
Any more you'd like to add to that, Dr. Matheson, of how Native history influences Native health disparities?
I would agree with Dr. Korn. The historical trauma, kind of starts this, and it just continues to feed. In today's world, there's even sort of now more of a cover up and keep it quiet and hide it behind the curtain, so to speak. Even though it's still going on, it hasn't changed. Anybody who thinks the playing field is level is just kidding themselves. And it's hidden. It's making it almost even harder today.
Yeah, go ahead, Dr. Erdrich.
I think we have to remember like the origins of Native American healthcare, and it started in the Department of War, right? And so immediately that's a conflict of interest. You know, those in charge of war were charged with the responsibility of Native American healthcare. And so I think with that inception, it's really going to have dramatic impact. And then I think even when given an equal opportunity, there's so much mistrust because of past abuses that it's then hard for a patient to participate. You know, like you carry so much into an encounter. It's not just you, it's what your mom said and your dad said and your grandparents said and what they experienced, and the things that have happened have created a lasting mistrust. So I think that's a really hard thing to overcome.
Agreed. Even when I talk to my own patients within the tribal healthcare system, a lot of patients takes a lot of conversations and building that trust back with Native patients, particularly with the Indian Health Service, where in the past there's been a lot of mistrust with healthcare system in general, across minority populations or even specific tribal populations as well. So I think there's definitely a lot of things which you all mentioned already: historical trauma, adverse childhood events, and a variety of other things we could talk forever about, but thank you for adding to the conversation. So next up, I'd like to transition to the current present situation of ongoing Native health disparities. So what I'd like to do is talk about a specific poll. We can pull this up, and I'm gonna give you guys like a couple seconds here to kind of figure out what are the major health disparities in Native communities. So this is more for the audience to do a quick poll of how things are going. And it's multiple choice. Okay, and then we'll see the results we got. So with the results, we got diabetes, heart disease, maternal mortality, substance abuse, suicide, violence. And all of these are all major health disparities in Native communities. So I'll leave a great job, everybody. Okay, so switching to our next section. So this is all about the present, current mortalities or things we face in disparities in our Native culture. So the first part, we'll go to the next statistic, is that a lot of Native women in our nation are 3 times more likely to die from a pregnancy-related cause than white women. This is according to the CDC. So this first question goes back to Dr. Korn here of tell us more about the OB maternal morbidity mortality for Native women.
Yeah, thank you for the question. This is obviously something that was very relevant when I was in North Dakota. I think before we can even get into that question, it was difficult when we started looking into this. This was my third year epidemiology project. It was difficult to even find enough research behind this because I think Native Americans are severely underrepresented in research. And there's a lot of different reasons for that. We're a very small population, so I think it's easy to get excluded or put in the other category. And so it was difficult to discern the maternal morbidity and mortality. But what we did in North Dakota, we compared American Indian and white women and controlled for a lot of different factors. And it was, I mean, it's not shocking, but it is shocking the results that pretty much every maternal poor outcome was higher in Native American women. So there were higher rates of preterm delivery, higher rates of intrauterine fetal demise. There were higher rates of breech presentation, and then separately higher rates of cesarean sections, even when controlled for breech presentation, as well as higher rates of C-sections after trials of labor, higher rates of macroscopic babies, and I think the list just kind of went on and on and on. And I think for all of us that, read these papers often, it's not super surprising, but I think what is the hardest part now is what we can do as physicians and what we can do as leaders in society to try and fix this. And so kind of next steps, we were looking at how many of these women were able to have access to prenatal appointments. And so I think that is kind of the next steps, is looking into how we can increase the amount of people that are able to show up to those appointments and receive education and higher risk screening for for the mothers and the babies, so we can help to mitigate this in the future. But it is very unfortunate, a lot of the outcomes that we found.
Thank you, Dr. Korn, and we appreciate your efforts in your service to the OBGYN community and serving our Native women for the future. So next up, I'd like to talk about the next statistic. We can pull this up here. So the next one is 4 out of 5 Native women experience violence in their lifetime, including 56% of who experience sexual violence, and this is according to the National Institute of Justice. So this next question goes to Dr. Matheson. Can you tell us more about the disparity in health outcomes for the ongoing missing and murdered Indigenous people?
This is sort of a subject that it comes up and it kind of gets covered up. Nobody wants to talk about it. Nobody wants to have the truth come out, so to speak. It is an everyday problem in not only the reservations, but in the urban areas. Like there's a huge Native population in Seattle. It's a huge problem there. It's on the reservations. And it's not getting any better because nobody wants to talk about it. Nobody wants to bring it forward. I was just at the Indian National Finals Rodeo a week and a half ago, and Thursday night was Wear Red for Missing and Murdered Indigenous Women Night, and they brought it to the forefront. And different reporters and different press were there, and they had never heard about it at the level we were talking about it. So the longer you keep it quiet, the longer you keep it buried, the longer this is going to continue. There's certain reservations that they can't even count the number of assault cases that are pending right now. They're just so many. And of course, working in the emergency room, we see it every single day. There's somebody in there with, domestic violence, sexual violence, kids, women, and it's not going to get better till they put it out front and people start telling the truth.
Thank you for answering. I know this is a very tough topic for a lot of our Native country out there as well. And specifically, do you ever notice any specific disparities or other health outcomes? Like how does it impact future health, I would say?
Huge impact in alcohol abuse, drug abuse, mental health, suicide rates, and then they get depressed and they get anxious and they don't take care of themselves, so their diabetes gets out of control, and they don't get, like Dr. Korn just talked about, they get poor prenatal care because they're abused and battered women and they hide. So it reaches fingers out into all parts of it: diabetes, hypertension, OB, mental health. It's all interconnected.
Thank you. Thank you. So the next question is for Dr. Erdrich. How do you approach Native patients and discussing cancer treatment and surgical options?
So one of the things when I first started this job, someone gave me really helpful advice about how I should talk about cancer with one of the tribal communities I'd be interacting with. And that's to not talk about it as their cancer, like to say you have cancer, but to kind of rephrase the wording. When a person has this type of cancer, the treatment is this. And so that's, very specific to the community that I'm working with the most, but I've actually found it to be a helpful tip across the board because it is so scary and intimidating. And I think the other thing that I try to make a conscientious effort at doing is trying to bring down the level of fear. So for a lot of the patients, I find that they consider cancer deadly, and there's just no other direction from it. And they don't know maybe the way the broader population knows that there are cancers that we can treat, that we can cure, that treatments are not as toxic as they had been in the past. So I do make a point of trying to bring some hope to the situation really early on in the encounter. And then I do have to think carefully through the surgical options, especially when something is multidisciplinary, and what that means for that individual because of just some of the limitations that happen with purchase referred care. So, which is a reality and unfortunate that there are limitations as to what we can offer Native patients sometimes because of simply there's not enough budget in the Indian Health Service to serve patients fully, right? And it operates on a life or limb policy. So, I try to overcome that by thinking of other ways we can get patients the resources they need. What if that means getting them enrolled in Medicare, Medicaid to try to fill the gaps that we can't accomplish through IHS purchase referred care dollars. So it influences a lot of our discussion.
Thank you. Thank you. So this next question is also for myself, or also for my panelists as well. What are the substance abuse accesses for treatment for Native patients, mainly from a cultural perspective? So my take on this is substance abuse is high in a lot of Native countries as well. A lot of substance abuse with alcohol usage, opioid usage, illicit drugs usage as well. And the way my community handles is that we have a dedicated bridge clinic in my outpatient clinics where the ER can directly schedule patients for our bridge slots so patients can get their treatments for alcohol use disorder, opioid use disorder as well. And specific facilities can have very tribally oriented, like cultural remedies as well. So in my community hospital, we have a dedicated Native medicine healers on staff where they can schedule direct appointments for patients and go through and speak to an actual traditional healer. We have both a male and female traditional healer, and we have our own like cultural center where we can have a safe space for Native healing and a lot of herbal remedies. So that's a nice aspect for patients to have in my community. This past summer, I did go up to the Shoshone Nation up in Wyoming, and they have a really great resource center for substance abuse. And they really do a deep dive in their cultural representation of words, of strength, resiliency. And it works for a lot of Native patients because in the end, we all have to come back to our tribal roots and grounds and to figure out how to best remedy our social situations and really combat substance abuse in Native country. All right, so we'll jump to the next topic here, is accessing care. So as we all know, accessing rural care in tribal communities can be tough for a lot of our patients. So this first question is for you, Dr. Korn. Tell us how the inequities in an unfunded system continue to affect Native healthcare.
I think we've all been alluding to it a little bit the whole time that there isn't good access on reservations, and there are many reasons for that. I think that for at least for funding, there isn't the funding there, and then also just the geography of it. Everything is it's much further apart than in the urban setting, and so there are a lot of barriers just within the geography of reservations of why there isn't as good of care. But then also, the systemic barriers that we've been talking about this whole time, that some reservations have been purposefully not given these resources. And I think that is a huge confounder to it all, of the lack of access and not having the federal support for that. And then not having that access leads to those problems that we were talking about. So going back to the prenatal example, not having that prenatal care down the line leads to poor outcomes for moms and babies. And I think similarly, we've all seen it in other fields, not having early screening for cardiac issues will down the line lead to further problems. So I think it starts very early, and we are not catching things that we should.
I see. And then Dr. Matheson, the question for you is, what barriers exist to access specialty care for Native patients?
There's a couple of them. One, of course, is the number of subspecialists or specialists that are out there. The numbers aren't very large, so you're trying to feed into a limited number of specialists. They typically are in some of the bigger, more urban areas. A lot of natives live out in the rural areas. So how do you get somebody 200 miles? How do you get somebody 400 miles? Everybody talks about e-medicine. Well, we can solve that distance problem with e-medicine. Great, but not everybody has a cell phone. Not everybody has wireless. Not everybody has a computer. So do you have to get these people into the community center, and then the community center you can connect up with the specialist? So you've got limits with money, limits to access, and the solving of that problem is not going very fast.
Thank you. And then Dr. Erdrich, how do you reach patients in such a rural healthcare system?
Well, kind of on the heels of what was just said, there's not a one size fits all solution. So it kind of takes everything, right? Yes, there's e-medicine. There's going out to the reservation. So I think that when an academic institution allows their physicians to spend time and have clinic on site, I think that overcomes some of the barriers, and it can't always be a unidirectional system that everything is referred out. Like, why can't we go on site? And then I think that well, I guess, yeah. I think it's about building bridges really from both directions, and using really every tool that we can. And if you can't set up a system where you're holding a practice, I think it means a lot when you go to your surrounding communities and just be seen. So like our cancer center has a lot of community outreach, engagement events that people come, they table, they just kind of demystify our system and show a friendly face so that it might be a little easier when you are referred and have to go, that it doesn't seem as intimidating. So I think showing up for public health events is important as well.
Absolutely. So things at my community hospital we do to reach a lot of our Native patients is we utilize multiple resources. We have a mobile van at our hospital where we actually can go out to like more public like markets or gas stations nearby to really deliver care to patients who can't travel that far. And specifically in a lot of Native communities, a lot of people don't have reliable transportation, and it's really hard to cross a great provide a reservation to get healthcare, and there's not much public infrastructure in terms of public transportation. So a lot of patients end up resorting to like hitchhiking on the side of the road or car hopping along with other people as well. So having a specific mobile dedicated van with the primary care resources to local areas has been very important for us as well. And another great resource we have is public health nursing within our public health service, where a lot of our RNs will actually go to patients' communities, deliver their medications, collect vitals, check on things, how patients are going as well. Specifically in the wintertime when the roads are really bad or when patients can't make their visits as well, we'll have our community nurses and providers actually go out to see patients as well. So that's been a really great, rewarding aspect as well. Another great thing that a lot of communities utilize is a lot of safe ride systems. So they'll have like transportation arranged for them to go to their specialty clinics, either like an hour away, 2 hours away, and to find transportation back. So that's a lot of things we use to really outreach to a lot of rural healthcare systems. And of course, with further developments of telemedicine and advancing technology, so a lot more connection with our patients. So we've been definitely utilizing that as much as well. So our next topic is the future. Like, how do we address future healthcare disparities, and what are some solutions we could potentially come up with here? And how to advocate and further advance and address all these healthcare disparities? We need more Native doctors. We need more fight to support our Native communities here. So we'll jump to our next statistic. So less than 10% of medical schools in the US have more than 4 Native American medical students, and this is according to the American Medical Society. So our next question is to Dr. Korn here. How do we get more Native med students?
I think it starts so early on. And there's so many different ways, but I think that early exposure and children or teenagers hearing the stories of other Native Indigenous doctors who have found their path and what their path has been, and that it doesn't have to look like everybody else. I think is step one, is just showing that it's possible. And then step two is programs like InMed. And for those of you that don't know, that's the Indigenous program at the University of North Dakota that specifically has X number of spots per year for Indigenous medical students. And so when you go there, you have support of people who share a similar background, which I think is, a huge part of making it to medicine is one thing, and then staying there is another. But programs like InMed, programs like ElevateMeD that help retain students is a huge part of it. But I think that importantly early on is getting the exposure to medical students, doctors who look like you, who come from similar backgrounds as you, and just speaking to them one-on-one. And that was another thing that we worked on while I was at North Dakota, is we would make ribbon skirts with younger children who were possibly thinking about medical school, and just talking to them about our journey. And it's just really interesting over even just an hour watching them evolve in their dreams and what can be possible. So I think it's just, we have to show them.
Dr. Matheson, since you're the president of the American Indian Physicians Association, how do we get more Native Med students?
That is sort of a topic that has just literally exploded over about the last 3-4 years. The AAIP is working with Mayo and the Mayo Press to publish children's books to give out to kids in grade school, where they can start reading about people who are doctors, nurses, lab techs, x-ray techs. Just let the kids read about it and get an exposure. We had the Native Indian Youth Conference through the AIP in Washington, D.C. It kind of went away. Well, we got funding back for it. So we're going to start that for high school kids. They're going to go to Washington, D.C., spend 2 weeks in Washington and talk to different people about healthcare careers. We're working on the new pathway programs, the PAWS, the pre-admission workshops, get high school students, college students, med students involved. Dr. Korn talked about the InMed program at UND. I'm now part of the InMed program. And the other one that people don't know about, but it's finally becoming public and getting out front, Dr. Don Warren, Jonathan Baines, Allison Kelleher, Kim Bernard are working on establishing a Native American medical school. They're into a feasibility study. They're looking at places like Rapid City, Alaska stepped up. So they're talking about having our own med student school. Well, there's 100 slots instead of, we're only graduating 20 to 40 Native students a year now. Well, all of a sudden there's 100 more. Just filling the pathways, educating people that if we can do it, you can do it, building a sense of community. That's one of the other problems. The statistic you just showed, 10%, only have 4 or more. That means 90% have 4 or less. The students have no sense of community when they get there. So we're trying to get more students in where the students will have a sense of community. Look at what Mary Owen's done up at U of M at Duluth. Look at what Wisconsin's done, U of W at Seattle. They have huge Native populations, a great community. InMed is another one. So there's a lot of things going on right now to solve that problem.
Absolutely. Dr. Erdrich, anything to talk more about how to get more Native Med students?
I follow that up, but so yeah, it's all of the above. I'll just chime in that hearing the presentation about the Indigenous School of Medicine at AAIP this year was so exciting. I couldn't sleep all night. Like I really could not fall asleep. So I think that that is going to be a huge answer to this question and make a big difference. It's a long time coming though. So it's important that all of the other work that's happening right now continues. I think there are other kind of homegrown things that we have a responsibility to do on our own. And I try to connect this idea of medicine in our culture. So it like to think of it as an expression of our heritage, right? Because we, for thousands of years, we've done plant medicine and we've had healers. And so the idea that doing something like medical school is out of reach is a myth, right? It's something that is actually it's in us. And so I think reminding young people that it's in our roots is important. And then I try to remind our current med students that they have a really special purpose in what they're doing in a way that maybe other classmates don't. So when you have to, study hard for that test, or you got to get up in the middle of the night for your third year clerkship rotation, what gets you out of bed? And for me, like I could get out of bed because I had this long-term goal that eventually I'm going to have a way to give back to our Native communities. And I think that is like a secret that can propel our students and our trainees, more so than I remember classmates like, why are you doing this, or what do you want to go into? Their answer would be kind of bland, like they just don't know, or their parents said they should do it. And having a community that you're doing it for, I think is like a secret motivation that we can promote more.
Absolutely. And furthering our partnerships, ElevateMeD has historically intentionally partnered with medical schools that have focused on this issue. So for example, there are currently 4 historically Black medical colleges: Howard, Meharry, Morehouse School of Medicine, and Charles Drew. So most of these Black doctors that do come from these schools, and we can definitely do the same thing with a dedicated medical schools to further support our Native students as well. So our next question here is, this is for Dr. Korn. You and I are finishing our residency. We're close to our medical school, but how do we maintain residents and medical students in this tough system we live in?
I think that's the perfect follow-up, because we were just talking about getting everyone to the door is one step. But then I think another challenge that we probably all face in med school is, okay, you're there, and now you have to give up this part of yourself for a little bit. For 4 years, you're not able to attend ceremony as much. You're not able to be around family, relatives, everything. And so I think that's a really challenging part that you don't quite think about as much before you arrive. And so again, going back to pathway programs, places like InMed, schools that prioritize having a community while you're there, I think is very special to have people in your class that know what you're talking about when you're saying things, and to have that shared sense of, we are here for this reason, we're all going to get through this together, is a really huge part of retention. And I think that it's challenging when you're in a different setting and you don't have that support. And I think now, coming to residency, being the only Indigenous person in my program, it's different than being in med school where I had, a dozen other people who I could talk to about things. And so it becomes, I think, kind of what we were just alluding to, of reframing your mindset, what gets you up every day, and then rethinking about that every day, or having someone else remind you that you're doing this for a reason. And so it is always a challenge once we get people there, but I think we are slowly growing the support to retain.
Absolutely. Dr. Matheson, how does AAIP kind of reinforce and maintain our Native residents and med students in this tough transition in life?
That is actually a new program that we are taking on. We're trying to work with like the Seattle Indian Health Board, where they have sort of focused on residencies that focus on Native American docs in their residency. And it goes back to what Dr. Korn said. How do we build community? How do we build a sense of belonging? Because if you're the only one on the island gets pretty unhappy pretty quick. So how can we feed in to these programs and get that sense of community, that sense of belonging, make people happy? Because if you're happy, you're moving forward, you're driving forward, you're bringing people with you. I can promise you, when I was an undergrad at Stanford, there were 3 of us out of 10,000. We didn't have community, we had lunch. That's all we had. So we're trying to develop and work with different places to build, especially Mary Owen up at U of M Duluth, family practice residencies, different surgical residencies. How do we build a Native focus for those populations to recruit specifically Native docs to go into their programs.
Absolutely. Dr. Erdrich, any ideas on how do we maintain Native residents and med students, because you work with learners all the time at the University of Arizona?
I feel like I skipped ahead and I kind of folded it into my last answer. So, I think I try to connect it to our heritage and try to connect community, right? It's the same answer, I think, for all of us, like that having community is huge. And having mentors is a big part of that. I can think of many times where it was game changing for me to be connected to a Native physician, or like when I was struggling with chemistry, the Stanford American Indian Organization found a Native American grad student in chemistry, like who could help me. So mentors is a big part of it, and in addition to everything else that everyone said so eloquently.
Absolutely. One of the things I was really looking towards in terms of support was the Association of Native American Medical Students, A&M for short. So that was a dedicated group of Native students like across the country who were in medicine and going through all the same challenges as well. And for myself, going to the AAIP conferences was really rewarding for myself, meeting great doctors who were doing great things as well, gaining mentors as well, but also in finding a lot of scholarship support through ElevateMeD. I've talked to my mentor so many times, especially when I'm going through interviews for residency, resume building. So a lot of the ways there's a lot of people to help, because you are not alone in this system of the medical system, especially as a learner, as a medical student, as a resident, even as attending. I've called so many people for help as well. So being a student for life has been very rewarding. So the last question for this section is, this is for you, Dr. Korn. What does being a Native physician mean to you to serve your Native patients?
It's such a privilege. I think walking into the room and having my little beaded badge or wearing my earrings and just having that little connection out here has been so meaningful. I really took it for granted being in North Dakota when, a lot of our patients are Native, and it was still special then, but I think just having that shared sense of community and understanding, and I think it also is a privilege in a way that we do get a little bit more trust. We talked about this earlier, the distrust in the system, and I think when you can bring it back to, we have this shared goal of making you healthier, and I think it's just automatically something that you can have in common together, and it makes it a really pleasant experience.
Thank you. Dr. Matheson, what does being a Native physician mean to you and your patients?
Like Dr. Korn said, it's a privilege. The feeling when you can walk into a room and have an impact because of your Native heritage and your Native culture that nobody else can have. That's a feeling that I feel sorry for some people because they miss out on that. They don't get to experience that. But that also taught me that with that comes responsibility. You have a responsibility to give back. You have a responsibility to put in the forefront Native Americans in their healthcare and work for them, because nobody else is going to do it. There's a small number of us. We're the minority of the minority. So with that privilege comes responsibility, and I'll take that responsibility. It feels good as well.
Great. Dr. Erdrich, what does being a Native doc mean to you and your patients?
Likewise, a sense of honor, that it's a privilege, that it is a really special thing. And I like how you phrased it. It almost feel bad that other people don't get to have kind of that. There's something really beautiful about being able to connect in that way. And there's definitely responsibility. I think that if we got here, there's a sense of, having had an opportunity that our other family members, relatives, peers didn't get to have. And so we have to honor them by doing the most we can with the education and training that we were given. And it's a give back, a community give back.
Absolutely. At least for myself, now I finished med school, now residency. I love being a Native doctor. I love talking to my patients because, as I mentioned earlier, the humor is there. The cultural things are there. It's such an instant connection. It's so great. I love wearing my bolo ties in clinics. Even when I was in my residency, I wore my Native attire all the time, my bolo ties, my jewelry. Always got questions about it. And the main question I always get is like, who are you? Like, where are you from? So I always love talking about my culture in that way, and seeing and really educating people who are not Native has been always a passionate things I've always grown up with through my education system as well. But I love my job. I tell my family I don't work a day in my life because I love what I do. So I'm really happy in that aspect. So those are all the dedicated questions I have for my panelists here. So again, thank you so much for sharing and you're raising awareness of the health risks and challenges faced by our Native communities. So with the next few minutes we have left of our session here, we can turn to the audience for a few questions. So the first question I got from as being the moderator here is this is for the panel. What can academic institutions do to help facilitate a better like research experience with Native Americans in terms of like research with rather than research on? And how do we get that information to inform better outcomes for Native patients?
I'll just throw in one piece. The AIP has actually just started an academic medicine subcommittee to address those very things, to do the research on the Native population, but in cooperation with the Native population. And then there's several programs that Dr. Don Warren's part of, Jonathan Baines is part of, the AIMS program, where we're increasing the number of academic Native American physicians. Dr. Erdrich, Annie Russ there at Mayo Scottsdale is doing a huge amount of research, academic research. She just was talking about publishing something the other day. So we have taken that on. It's starting to grow. It's coming to the forefront, and we're pushing that and pushing it hard.
Absolutely. Thanks so much. So our next question is, what is the best way to advocate more funds per capita for the Indian Health Service?
Well, I'm meeting with Senator Hoeven in a couple weeks. He's on the Indian Affairs Committee. We all know that the BIA and IHS is woefully underfunded, but we're going to keep pushing. They're talking about opening an advocacy office in Washington, D.C., where we have policy people to do that very thing. How do we get more funding? How do we get it out to the forefront? We're working with IHS every day through the AIP and others to increase that funding.
Yes, so talk to your lobbyists, talk to your representatives to advocate for more for our funds for our IHS facilities and clinic sites. So the next question is, does the panel think that the Western medical education system is the best way to create a strong next generation of healers for Indigenous communities?
I think that Indigenous medical school will address that in a very large way, because they're talking about having sort of the traditional Western curriculum, but also including a more, traditional Native curriculum as well. And the AIP every April has the cross-cultural medicine workshop last weekend of April in Albuquerque with the Gathering of Nations. And it is a meeting that focuses on nothing but how you marry up the Western medicine with traditional medicine. Last year was the biggest one of those we've had. We had over 60 students. So the students are jumping in and getting involved in it as well.
Indeed. And I think having a voice in these educational communities or retaining medical students as well, somebody having a Native in academia, having that voice, I think is so essential in how to recruit and retain our Native students as well. Got another question here. Are you aware of a database of current practicing Native physicians to reach out to specifically for research collaboration?
I can tell you the AIP just put a new platform in their computer system. So we're going to be able to track Native physicians who belong to the AIP by region, by specialty, by academics, by research. It's just evolving. We're putting in the data, but we will have, at least amongst our membership group, a database probably within the next 6 months.
Absolutely. Well, at this point, we are running down on time here. So I want to thank so much for the panelists, Dr. Erdrich, Dr. Korn, Dr. Matheson, for all your expertise and leading our way in our native country as well. So we thank you for your service. And I also want to thank ElevateMeD for putting this on, Dr. Porter Umphrey for guiding us as well as we continue to combat our health disparities and how to address them as future physicians as well. So I want to thank you so much. We are wrapping up here. We hope to see you again for other ElevateMeD events. Thank you so much. We can learn more about us and how to get involved at our website, elevatemed.org/friends. You can follow us on social media, Instagram, Facebook, LinkedIn, and Twitter at ElevateMeD Incorporated. Thank you, everybody, so much. Have a good night.